Hi, everyone. Thank you so much for joining us today in our age-friendly geriatrics teleecho series. We are very excited for today's topic on oral health and dementia within the 4Ms. As you all know, we're just going to get started with our introductions and welcome and announcements. We'll then move on into our didactic. And I know Dr. Tabrizi will go ahead and leave some time for questions at the end. And then we'll end with some of our closing and reminders. As you all know, you guys are muted upon entry. So if you do have any questions or anything, you can go ahead and put that in the chat or unmute yourself when it's time for the Q&A. We are CME accredited, and this session is approved for one AMA PRA Category 1 credit. Physicians should claim only the credits commensurate with the extent of their participation in the activity. And the California Board of Registered Nursing does recognize CME credits as transferable for their members. So nurses may receive CEUs after submitting their UC Irvine attendance certificate directly to their board. Usually you'll get those within a month. So if you have any questions about receiving your CME certificate, you're more than welcome to email me at any time. This project is supported by the Health Resources and Services Administration. And this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. We always like to start with introductions and announcements. So if you are on the line, we'd love to see where you all are joining us from by putting it in the chat with your name, your role, your site, and your location. It also helps us with attendance and giving you guys your CME credit. So please put that in the chat. And while you do that, we'll go ahead and have our hub team introduce themselves. I'll go ahead and get started. My name is Nika Seville. I am the GWEP project manager here at UC Irvine in Orange, California. And I will go ahead and have Dr. Pereira introduce herself.
Hi, everyone. I'm Manisha Pereira. I'm one of the geriatricians here at UC Irvine. I practice in Orange, and I also see patients at skilled nursing facility. Welcome, and I'm looking forward to this presentation.
Thank you so much. And let's see, I will go ahead and introduce Dr. Tabrizi, who is on the line. Dr. Mariam Tabrizi joined the UNLV School of Dental Medicine in July of 2022. And prior to UNLV, she served as faculty in the Department of General Dentistry and Public Health at the University of Texas Health Science Center in Houston. She's earned many certifications, including a geriatric fellowship certification in the Special Care Dentistry Association certification in managing health and chronic conditions in older adults in association with the American Society on Aging, and certification in Tideswell Emerging Leaders in Aging Program for Geriatric Leadership. And prior to her academic professional career, she maintained a private dental practice for 20 years in Pennsylvania. Dr. Tabrizi earned her RDH, DMD, and MPH at Temple University School at Dentistry in Philadelphia. And we're really lucky to have her here today. Again, Dr. Tabrizi, thank you for being here. It looks like we have a wonderful group of people on the line at the moment. So thanks for joining today's session. And I will go ahead and stop sharing so Dr. Tabrizi can go ahead and share her slides with you today.
Thank you, Nika, for that great introduction. It's great to be here. I have such a passion for what I do in oral health in areas for populations that are doesn't even occur to a lot of people and even health providers. So here we are talking about oral health within dementia and the 4Ms. Nika, is my screen being shared properly?
No, not yet.
Okay, so that's what's happened here. Because I keep saying, well, where is my... All right, let me... Are you giving me the permission to share? Because I don't see that little box of share screen.
You should be able to. I can share the slides if you'd like me to.
Go ahead and share my slides,
okay.
Because for some reason I can't see that share screen button.
No problem.
Okay. Are you on the very first slide now?
Yeah,
Because
yeah.
now I have to. Okay. So today is October 18th, and here we are. So what is oral health within the whole health disciplines? I found this code here, and I see this very, very much fitting to what we do here. Is coming together is the beginning, keeping together is a progress, working together is a success. And it all defines into how we start with interprofessional education that will lead to interprofessional collaboration, because there will be no collaboration without education. And this is the platform to actually what we learn, how to include everything, including oral health, into the whole overall health. We're trying to address two topics here. Obviously, trying to bring in oral assessment. It does not mean oral diagnosis. How to bring oral assessment with among patients with or without dementia, actually, I must say, by non-dental providers. And also how to create that next generations of providers that are educated enough to be able to collaborate, which is basically how to come together as a team and work with a patient, that person-centeredness that we all are aiming for. So what is the problem? The problem is that why is even has to be part of a healthcare? Because the population that we are serving as a age-friendly health system and the 4Ms is definitely increasing, and this problem is not going anywhere anytime soon. The problem is that there is the shortage of a trained dentist even. The gap between trained dentists and other healthcare professionals is increasing because the number of population are increasing, and the number of trainings it's staying the same or even decreasing. So the gap is huge. To be able to close this gap, the interprofessional education and collaboration has become a big part of actually healthcare for dental and non-dental, because oral health, we are realizing more and more that how much is associated, if not directly impact on a lot of chronic conditions. So the aging mouth. What is the aging mouth? The aging mouth is it's the process of aging, normal aging, that mouth can go through, the normal wear and tear, as we call it, and also the increasing risks for certain conditions, like cavities. People say as we get old, we don't get cavities anymore. Well, we do. It's not just on the chewing surface of a teeth that most people do, but it's on the roots, because the roots, as a result of recession, which is again part of the aging, receding bone, receding gums, individuals end up having exposed roots, and cavities actually can form on the roots. And because the root surface is not as strong as enamel, it spreads a lot faster, and a lot faster leads to tooth loss, and of course increasing in oral cancer. And so as these things happens as maintenance, for so many different reasons, their barriers are countless. The maintenance decreases as a result, it becomes a vicious cycle. Decrease in maintenance to more oral diseases, and the worse the condition gets, it's harder to maintain. So, but again, we all know that as a whole, having a comprehensive health is health in balance. So I thought this is a good diagram to show how everything can come together and needs to balance up with with oral health. A lot of times this the problem with oral health leads to conditions, especially malnutrition and a lot of other issues. We talk about them. That is, it's very difficult to relate and connect when we don't have that basic background, basic knowledge of oral health, that what can lead to this. I'm going to talk about it in a few minutes more, but one of the number one things is dry mouth. Dry mouth it's a foundation for a lot of issues that most of us, including dentists, we don't see that as a serious problem. So bringing all these together is I just want you to understand that this is not about teaching non-dental providers how to do dentistry or even how to diagnose dentistry, but it's all matter of how to also assess the oral health as we assess everything else. And the reason for that is here. When we go to a memory care, and that picture in the center is actually, I took that picture when I walked into a memory care a couple years ago, and this hall is actually called activity center. And the activity center is basically bringing residents, putting them all in one spot, and as you can see, there is not a whole lot of activities going on. But what happens here is, the reason I brought this in, that how difficult is to expect the mouth, which is not something everybody sees as soon as you see somebody's face, how easily it can get neglected. And the other thing that it's important to know, I really don't like to call this dental care or dental health, because oral diseases can happen in a mouth without any teeth. And I have the picture on the top left. The fungus infection is actually occurring on the tongue of a patient totally edentulous. And that, when I saw that, it wasn't actually a safe thing to remove all that bacteria, all that fungus infection, because patient's ability to swallow is less. And once that bacteria, once it will go to the lungs, when it goes down to the stomach, there is a huge risk for actually pneumonia that they can get. And a lot of patients, unfortunately, there is not enough study yet, but we all know that a lot of patients, as they go to aspiration pneumonia, most of the bacteria actually comes from bacteria in the mouth, such as fungal infections and gum disease, caries, or things in that sort. And also herpes lesion, which is very, very painful. And usually when older adults, especially in memory care or even hospice care, when they get this, communication is an issue. The first thing they do, they start acting out. So it's not they are misbehaving, they're just hurting. And they stop eating because everything comes closed in mouth hurts. So there is a lot of issues here that we can talk about, that why assessing of oral health for this population is not an option. is a must. And something else that I came across again with a patient in memory care, that this young lady, she was about 97, she broke a crown. As you can see right here, she broke a porcelain crown. The porcelain crown left a very sharp edge, and as a result, put a very deep, painful cut in a lower lip. When that happened, again, because of she was nonverbal, she just cried and stopped eating. She was actually increasing for certain medications. It took about a couple of weeks before we got called in, and I saw that was actually a localized issue, not a systemic or a behavior or a mental issue. So the more I bring this into reality, I hope we all get on the same page that how important it is for especially non-dental providers to just take a look at overall mouth and have some kind of assessment on that. And as mental health and including by mental health, it can go from a mild depression to actually very advanced dementia, but any and everything else in between. As depression and a state of mind decreases, the risk for oral and negative oral health conditions increases. The first thing that happens, even if it's not in late life depression, the first thing that it does, people with in a way at any age, more so in older adults, but individuals at any age, when they get depressed, like clinically depressed, the first thing they do is self-neglect. They don't take showers, they don't brush teeth, it's just part of clinical depression. And that the problem magnifies in late life depression. So as a result, when this happens, when that mental health hits, and most of the time these people also are taking certain medication like antidepressant, anti-anxiety, they usually don't sleep properly, they get medication for sleeping, even chronic pains that they might be involved with. So there is the lack of self care, and the medications that take all comes together and yields the conditions in the mouth that is as much of a high risk for a lot of conditions. And for name a few, as I said earlier, for just cavities, gum disease, periodontal disease, lesions, and I get to talk a little bit more about how important it is to look at if there is any lesions anywhere. So what is the I kind of thought if I put this in a table, it's easier to see that how oral cavity, what it is, what it's formed of, and what is normal aging, what is not, so we be able to at least just recognize normal and abnormalities. The whole oral the whole mouth, the whole oral cavity is a very complicated components. It forms with structurally is associated with skeletal muscle, muscular components. There is a joint there, TMJ, two major components of one, mandible and maxilla. Maxillary is a fixed component, mandibular is a mobile component. So it all come together and form a mastication, which is remarkable in action and behavior, which is actually the first stage of digestion of food. The better the food is chewed, the more saliva is involved, the better the digestive system will get. and it's exactly opposite of some people think as we get older, oh, we don't need teeth anymore, where the digestive system is a lot weaker and actually needs that first stage of the digestion of food. And also unintended usage of this organ, I can say, it actually can lead to problems that are not reversible. For example, a lot of older adults, especially with mental health, they sometimes, as a result of certain medications, they clinch. The whole process is bruxism. And as you can see on this table, I don't want to read it, but there are certain things that are normal. Discoloration, sometimes recession. These certain things happens in time, but it still is functional and it still considers healthy. Certain things are not. And I categorize these topics into 3 categories: the good, the bad, and the ugly. So what we call good, the good is discoloration, the natural wear and tear. Sometimes as a result of the wear and tear, we call it attrition, we may get gaps and spacing between teeth. But as you can see, the teeth may not look pretty, but they definitely are disease-free, they are healthy, and they are functional. And that's very important for us to recognize what's healthy. And they know the easiest way is ask. Well, I get to that because I that's a very important part of asking the question as a part of what matters most. So what is bad? What considers bad is it's not healthy, but it's not life-threatening. It needs treatments, it needs care, but as a result, it's reversible. That's the best way to put it. How does that happen is, as you can see in this picture, actually I have another one I want you to see. In both of these pictures, one is right here is the lack of maintenance on a natural teeth. And as I said, we have gum recessions here, roots are exposed, and all the root surfaces of these teeth have been decayed. But this person is actually in a nursing home, and the oral health maintenance is minimum to nothing. On this side, this man had, he was in memory care. He has this partial denture there that nobody knew he had, including family. When I looked at him and I realized this partial denture was sitting there and nobody knew, even I talked to the family, I talked to the caregiver, nobody knew he had one, even though when he got accepted into the facility, when I looked at the chart, it was not marked as a removable prosthesis in his mouth. Therefore, this piece of plastic was left in his mouth, I can only assume, for a minimum of 5 years. You can imagine how the tissue was feeling and looking like, and what it took for us to even be able to remove this, to look at what's going on underneath. So that's a bad, and I must say very bad situation. Situations like this, like here, this patient actually had angular colitis, which is a fungus infection as a result of drooling excessively and the lack of oral hygiene. That bacteria actually gathers in this crest and make that, in fact, the fungus infection there. And I don't know if you can see it, but right in that spot, I could actually see the pus, the white active pus. And somebody thought it was dry and they were just applying Vaseline on it, and it really wasn't helping, in fact making the situation worse. But certain things that definitely need to pay attention to, just to make sure that our residents, our patients, they are not dealing with constant pain and active infections. This is a best example of total dryness. This woman was so dry due to a lot of medications that of course she was on. She couldn't even talk for more than few words because it actually would hurt her. This one back here, this gentleman actually had a couple dental implants, and his denture was actually screwed on top of these implants that are not easy to remove. But again, when it was constructed, it was with the intention of the patient sees his dentist every 3 to 4 months to actually remove these, unscrew this, remove this, clean it, the gums, and put it back on. Well, as you can see, that never happened. Even though only 5%, as you all know, older adults may end up with facilities or dementia, but that 5% is millions. That is too many people to overlook this issue, the whole oral health issue. So as a result, I don't know if you can see, but there is a lot of ulcers here. The tissue was very, very angry, infected, rolled in. So there are issues. I'm just bringing the conditions that how we can see something is not normal. So what is ugly? The ugly is malignant oral lesions, life-threatening. In this case, which was very unusual, this was a metastatic cancer, which normally you don't see it the manifestation is not orally, is not in the mouth. This is actually a metastasized renal cells carcinoma. As you all know, that's usually the cancer sits on the kidneys, and somehow it metastasized into the oral cavity, and it took so long to be diagnosed by a dentist, even though this woman was going to see her primary physicians, I'm sure. But once we saw it, and this was a case actually we saw in Houston, by the time we saw this woman and it went to biopsy, go through the process, it only took about 6 to 8 weeks or less. Maybe I want to say 4 to 6 weeks. But by the time we saw her, she went to for biopsy and come back, it was too much. It was too late. It was metastasized. It became life-threatening, and unfortunately the worst did happen. But what I want to say is 8%, which is it's a big percentage. 8% of overall all cancers are oral cancer, and out of this 8%, 75% of them happens later in life. 65 and older, and definitely 75 and 80 and older. So as they get older, their risk is higher. Another case of ugly was this 96-year-old man that had bridges from his whole mouth was basically reconstructed, and under these, again due to lack of maintenance, he ended up having multiple infections. And when I saw him, I mean, he was for his age and his condition, what he was dealing with, we had to send him to emergency room. So this is something I actually put together when I was when I was in Houston for our program there. This is a overall is a very short modified short form for Kaiser-Jones brief oral health status examination, which can be used by non-dental providers. And basically looking at certain categories, looking at certain things, and basically market what's normal, what's not. If there is any lesions, if there is anything that's not supposed to be there. I mean, I showed you a few pictures that we all don't have to be a dentist to know, well, something doesn't look right here. So acknowledging the abnormalities, it's a first step and a huge step to be able to prevent a lot of those ugly situations. By the way, you're more than welcome to have this this form if you like to use it. And these are more, I'm going to have a few more of these pictures that you can see it's just not normal. Some of them are cavities, some of them are fractures, some of them are infections, some of them like this one here as a result of some medications that he was a stroke patient. He was on beta blockers that actually causes tissue overgrowth, and plus bacteria, of course, it happens. And he had some broken teeth that tissue overgrew so much that actually covered those root tips. We couldn't even see them. And then this one looks like a lesion in a back under the tongue, and it kind of looked a little strange to me when I first looked at it, and then looking a little closer showed that he had a silver amalgam back here that was fractured, and as a result this was nothing more than a trauma. So all the ugliness that at first I thought, oh my God, what is this? Thank God that wasn't the case. So we just smoothed this little sharp spot there, and about 2 days later, this was gone. So again, just looking in the mouth, that's all it takes sometimes to be able to eliminate, and the agony, the pain that they can most of the time, especially in advanced dementia, to be able to communicate, and then it leads to misbehavior, and it leads to malnutrition, and it just list can go on. And sometimes post-stroke patients are in rehab. Again, that's the area to look at for these things, because asking the question, initially asking the question as a part of what matters most, it's very important, because as we all know, culturally and historically, patients don't come to dentists talk about their heart, and they go to primary dentists and talk about their mouth. When we start asking questions, we allow that, and by allowing that, we be able to actually assess the whole person. It's okay to ask if they are wearing anything removable, any removable teeth, or if they do, if they fit right. Because if they don't fit right, they're prone to fracture. They impact their social there's a social status. They are out to lunch with friends, and then denture falls down, or food gets under it, and they constantly have to run to the bathroom. I mean, if you have older adults in the family, you know exactly what I'm talking about. And in this one case, a emergency physician that happened to be the husband of one of my students. Is anybody talking to me? So anyway, a loose fitting partial denture ended up, patient actually swallowed it. This was seen in an emergency room. The emergency physician saw a tooth in the back of her throat. They take x-ray, and here it is. Very rare, extremely rare, but obviously has happened. So I'm going through this a little quicker because I definitely want to allow time to Q&A. To be able to fit this in a 4Ms starts with what matters most. To be able to ask the patient if there is, as a part of a patient health questionnaire, to be able to ask if they are eating well, if anything hurts when they eat, if they're comfortable with their function, what kind of medications they take. There are so many classes of drugs. Just consider 90% of medications prescribed or over the counter do cause dry mouth. Dry mouth puts patients at risk for lesions, for cuts, for pains, infections, fungus, you name it, because the saliva that has all those good bacteria and enzyme for cleansing, it's not there. It naturally makes the oral health environment an acidic environment that bacteria can easily grow. And mobility, again, if they're comfortable brushing their teeth, and mobility, the one thing I want to add to this is mobility is not being just a physical movement. Mobility can be eyesight, can be driving, can be access, finances, anything that blocks patient between patient and care falls into the mobility. So it's kind of here as a physical limitation, but in reality, I'm wearing my public health hat now. It doesn't end there. Just little information just to keep it in the back of your mind. So how are we going to assess and train the future healthcare providers to be part of this? Pilot studies are usually the best thing. How do we bring this in? How do we bring oral health into the age-friendly health system? Obviously, by putting it into the 4Ms framework. And recognizing what our learners need to be able to assess. Based on that, create an educational training, develop curriculums that they can actually assess oral health as a part of examining the patient overall. And rapid cycle quality improvement is a best way to quickly evaluate if the educational program we have, is it working, is it going anywhere? And in a short term, this study can tell you exactly what needs to be done, what modifications need to be made, and where we can fix the problem. At the end of the day, it's a teamwork. All of us, we need to close this gap. And actually, this is self-explanatory. I don't think I need to go deep into that. This is important. I kind of took the age-friendly health system, the hospital flow, and primary care flow, and I put oral health in a wonderful world. If we put the oral care questionnaire right in the beginning, right as patient comes into the system in a 4M screening, right there, oral care, oral health comes in with the patient, both in a hospital flow and primary care flow. And sometimes all it needs, it's a brochure or a picture or a question, just opening that door, allowing patients who come to anyone except dentists can still talk about oral health and with their complaints, what matters and what's the issue. So I actually think this is one of the my favorite slides that I pretty much put it in all my presentations. So with that, I pretty much covered everything I had to say. I have 10 minutes for you all to any comments. Comments are just as important than questions. Any comments that you have for me, I'll be more than happy to hear and respond to any questions you have.
Thank you, Dr. Tabrizi. I think we had a comment in the chat that Mitchell Erickson stated, I worry about making a general survey assessment, but then not being able to refer the patient to dental care, inability to pay, or lack of insurance or minimal availability of free dental care.
That is all valid. However, I've been, all I can say from experience, what I can say is assessing and recognizing the problem is one thing, how to address it is another. So what I see is, oh, thank you for stopping sharing my screen so I can see you all. As a result, what I can see is, because every health center, I must say, every hospital, or even